Chapter 26, Concurrent Disorders During Pregnancy. The following slideshow, we're going to talk about disorders during pregnancy, the role of the nurse in these disorders, and any kind of key concepts to really consider with these disorders. First one we're going to review is diabetes mellitus, complex disorder of carbohydrate metabolism, going back to your basic kind of fundamentals for med-surg when we learned about diabetes. A little different in this patient population because we know just understanding the differences in diabetes mellitus with our special patient population of pregnant women and the developing fetus. Diabetes mellitus is caused by a partial or complete lack of insulin secretion by the beta cells of the pancreas. Without insulin, glucose accumulates in the blood, known as hyperglycemia. Some classic symptoms of diabetes we know is polyuria, polyphagia, polydipsia. The effect of pregnancy on fuel metabolism. So early in pregnancy, small changes in the metabolic need can really impact a patient who has a history of diabetes mellitus. Insulin releases in response to serum glucose levels, and it accelerates. So these patients are kind of putting out high amounts of glucose, especially due to the changes in their metabolism and due to the needs placed on their body from a developing fetus. So these patients kind of might experience a little bit of hypoglycemia. Their high levels of glucose are being absorbed and used pretty rapidly due to the metabolic changes that they have. So these patients might have periods of lower drops in their blood sugar more frequently than in a non-pregnant patient. Effects on late pregnancy. Fetal growth accelerates. So these babies can become large for gestational age due to kind of that amount of glucose circulating in the bloodstream. There's a rise in placental hormone levels. Hormones create a resistance to insulin. So these patients who might not have required medication management in the past may require medication management at this time, and they might have fluctuations that are very different from their norm for their blood sugar levels. During birth, maintenance of normal maternal blood glucose is essential during birth to reduce neonatal hypoglycemia. The common kind of rule of thumb is that whatever mom's blood sugar level, baby's blood sugar level is lower than that. So we really want to avoid periods of hypoglycemia during labor and delivery because we know that our babies will be much more hypoglycemic than the moms. We really want to avoid those periods in labor and birth. In the postpartum period, the need for additional insulin fails. We know those metabolic needs and demands kind of change, so their need for medication will change as well. Breastfeeding is encouraged for patients who have a history of diabetes mellitus. The added calorie intake by the mother helps to lower the amount of insulin needed in women with type 1 and type 2 diabetes. The woman with gestational diabetes usually needs no insulin after birth, and they'll usually be about one kind of fasting blood sugar check to kind of assess their changes in blood sugar in the postpartum period for those patients who had developed diabetes during the pregnancy. Classifications of diabetes mellitus include type 1, insulin deficient. Type 2 is that insulin resistance, most common type. GDM is the onset of glucose intolerance during the pregnancy, so very specific to the pregnancy itself, and this is usually a precursor to a patient's likelihood for developing that type 2 insulin resistance diabetes later on in life. Incidence, diabetes mellitus is a common medical condition. About 90 to 95% of diagnoses are type 2, like I said, the most common. Type 1 accounts for about 5 to 10% of diagnoses, and about 10% of all pregnancies are affected by GDM or gestational diabetes mellitus. Pre-existing maternal effects. During the first trimester, we talked about those incidents of hypoglycemia and ketosis there. Increased incidence of spontaneous abortion and major fetal abnormalities. And these are for patients who have the history of diabetes mellitus. Again, why understanding and knowing a patient's pre-existing conditions are highly important in the health management of these patients. Preeclampsia is 2 to 3 times more likely to develop. So for these patients, it's important that we continue great health maintenance during the prenatal period so that we can assess for any of these issues later on in the pregnancy. Premature rupture of membranes is also a high risk for these patients, as well as macrosomia, or that large for gestational age, those developing those large babies. Pre-existing conditions, kind of fetal effects there. These are patients who are higher risk for congenital malformations, variations in fetal size, such as small for gestational age, intrauterine growth restriction babies. So we know that there's an issue there with the placenta and growth for babies, kind of on both the small spectrum as well as large spectrum. So there's some growth restrictions there. Neonatal effects. So we know that these newborns are at high risk for hypoglycemia, especially if mom had hypoglycemia during labor and birth. Hypokalemia, we know that kind of goes hand in hand with that diabetes mellitus picture. Again, pulling back on that baseline information that we have and that knowledge we have from our med-surg backgrounds. These babies are also at higher risk for hyperbilirubinemia, so it's important that we monitor those babies, especially in the days preceding birth, typically day 2 to day 4, as well as for any respiratory distress syndrome. And that could be both related to the birth itself as well as related maybe to the size of the babies. Maternal assessment includes history, onset, and management of diabetic conditions. These are patients we want to monitor their medication management and or the need for medication management. Physical exam, we might want to have some additional lab work, maybe some additional information such as an ECG or a ophthalmic referral if we are concerned about these patients' eye health. Laboratory tests, we want maybe a baseline 24-hour urine to assess any sugar in the urine itself, as well as a great analysis on their hemoglobin A1C. So that can give us the best picture of how their diabetes control has been. Surveillance, especially for the fetus. Surveillance should begin early for women with pre-existing diabetes. We want to be testing for abnormalities, frequent ultrasounds to help us kind of monitor this baby's size, fetal echoes if need be, if we're concerned about any fetal structures in the heart or blood flow in general, as well as fetal kick counts and activity count for these fetuses. Therapeutic management of a patient with diabetes mellitus includes maintenance of normal blood glucose levels, the facilitation of the birth of a healthy baby, avoid accelerated impairment of blood vessels and other major organs, preconception care, diet, self-monitoring of glucose, as well as any medication management, such as insulin therapy. So these are the patients where that preconception management is really important, and really assessing their health and safety prior to becoming pregnant is very important to make sure that we can kind of monitor a patient's pregnancy from a very early stage. Risk factors for patients who might have diabetes include patients with higher BMIs, patients who are overweight and obese, maternal age greater than 25, GDM in previous pregnancies, history of abnormal glucose tolerance tests, and we do that during pregnancy, usually during the second trimester, family history of diabetes, again why it's so important to get a nice in-depth health history of these patients, as well as members of high-risk ethnic groups. Some screening for diabetes mellitus includes that glucose challenge test. So that's what we were talking about just a moment ago. It's done during that second trimester of pregnancy. It's a 1-hour test where a patient consumes 50 grams of oral glucose solution, and they have an assessment of their blood glucose levels preceding the consumption of that glucose. A challenge test is an exam where we look at it in about a 3-hour period, that oral glucose tolerance test, and we monitor that blood sugar a little bit more closely. And that would be if we obtain an abnormal value during the initial glucose test. Therapeutic management for patients with diabetes. We want to make sure that these patients are seen by registered dietitians as a great way to really talk about their nutrition, especially if this is a new diagnosis for them. We want to discuss at length recommendations for weight gain for these patients, especially during pregnancy. We want to encourage exercise during pregnancy, really close monitoring of their blood glucose, and the additional antenatal testing that might be required for their fetal surveillance during their pregnancy. Nursing considerations, we want to increase effective communication with these patients. Education is key, talking about what expectations they should have, what kind of testing to expect, as well as the risks of having babies be born to diabetic mothers. We want to kind of review what the outcomes might be for them. We want to provide opportunities for control for the patient, as well as provide pregnancy care that is still within normal limits. So talking about what other prenatal care testing is also important for them, not just because of their diagnoses of diabetes, but also because of their gestation. Pregnant women with diabetes. Again, assessment is always going to be our foundation. We want a nice thorough history, that onset and management of their diabetic condition, especially if it differs in a non-pregnant state versus the pregnant state that they're in now. Physical exam, we want baseline ECG for them. Again, that ophthalmic referral, changes in their height, weight, and blood pressure, any kind of values we can obtain from there. 24-hour urine, again, looking at that hemoglobin A1C, as we had said before, getting a really thorough intake on our baseline information. Interventions, teaching self-care skills really goes a long way. Understanding what's important to teach for patients who are perhaps new at taking home blood glucose monitoring, understanding what skills are involved in that, what's important for these patients to know when going home. Instructions on insulin administration, if applicable. Continuous subcutaneous insulin infusion, understanding what that means, what patients might be at risk for it, so on and so forth. Teaching dietary management, even in patients who are managed pharmacologically. Really important to kind of bring home those teaching points in dietary management as well. Especially knowing that in pregnancy, our nutrition should really change to kind of increase our protein a little bit and increase our dairy items as well. So we want to make sure we're meeting those standards, as well as finding a diabetic diet that's appropriate for the needs of our patient. Recognizing, correcting hypoglycemia and hyperglycemia, teaching patients what the differences between those two are, as well as ways that we can alleviate those symptoms if they're experiencing them, and explaining procedures, tests, as well as their plan of care. Cardiac disease. Cardiac disease complicates about 1% of pregnancies. It remains a significant cause of maternal mortality. Two major categories of heart disease are rheumatic heart disease and congenital heart disease. Some classifications, again, going back to that rheumatic heart disease. Sometimes follows a diagnosis of streptococcal pharyngitis, which occurred in childhood. It may cause scarring to heart valves, which is important to know, especially as our blood volume changes and increases during pregnancy. The mitral valve is the most common site of stenosis, may lead to pulmonary hypertension, pulmonary edema, or congestive heart failure. Congenital heart disease, left to right shunt, atrial septal defects, ventricular defects. Important to kind of know the etiology and the pathophysiology involved in the type of congenital heart defect our patients may be having. That really is going to dictate or more individualize that plan of care for them when we understand the root cause of the cardiac disease. Assessment and specific signs and symptoms of cardiac disease are part of every initial prenatal visit. Again, laying down the foundation to good prenatal care. Things that we look for, those signs and symptoms of dyspnea, syncope, any dyspnea at night, chest pains with exertion. So we review that information with patients and talk about what normal changes would happen during pregnancy that might exhibit periods of dyspnea. Severity of the disease is determined by the ability to endure physical activity. So kind of monitoring what the level of activity for our patients are. Therapeutic management includes understanding the class of heart disease. Again, that class 1, class 2, class 3, or class 4, the drug therapy included for these patients. Are these patients on anticoagulants? Are they at high risk for clots? Are they patients who require antibiotics in labor? Are they patients who are on antidysrhythmics? It's important that we understand what medications these patients are and how they could impact fetal development. Intrapartum management. 300 to 500 mLs of blood is shifted from the uterus and the placenta into the central circulation. Extra fluid causes a sharp rise in cardiac workload. So not only are these patients having an additional increase in cardiac workload because of the labor they're enduring. We also know that they're having an increased amount of fluid, which can really be very, very critical for patients who have history of cardiac disease. They might not be able to tolerate that shift of fluid within their body, so you might want to minimize that. Vaginal delivery is recommended for women with heart disease unless there are specific indications for cesarean birth. For example, patients who are not cleared to exhibit that valsalgia or kind of bearing down motion with each contraction. So we want to make sure that our patients are cleared from a cardiac perspective in order to push for that vaginal delivery. We want to minimize maternal effort and that use of valsalgia maneuver. So we want to hopefully help that baby kind of labor down and come further into the pelvis to minimize the physical exertion on mom. We want to limit prolonged labor for these patients. Postpartum management, also a very critical time for these patients with this history of cardiac disease. Although there's no evidence of distress during pregnancy, labor, and childbirth, women may have cardiac decompensation during that postpartum period. And this can be due to big shifts in the amount of fluid a woman has within her body as she goes to that pregnant state. She labors, she delivers, has a loss of fluid, and now she's in her postpartum period where the fluid is shifting. Blood from the placenta and uterus increases that workload from the heart. So close observations for signs of infection, hemorrhage, and thromboembolism for these patients are absolutely critical. Conditions can act together to precipitate postpartum heart failure. So these are very high-risk patients, especially in that postpartum period. Signs and symptoms of congestive heart failure include frequent productive cough, or maybe cough that's bringing up some blood in it. Progressive dyspnea with exertion would also be a sign and symptom here of congestive heart failure. Changes in edema, such as the patient exhibiting pitting edema in the legs and feet, are generalized, especially if it's a new onset. Patient might themselves be experiencing heart palpitations or any kind of moist rails in the lower lobes, and we're auscultating their lungs, indicating that pulmonary edema. So, nursing process with patients with heart disease. Assessment, again, I've been saying it for probably longer than anybody wants to hear. Building on those physical assessment skills as the true foundation to taking care of our patients. How do we know if they had a change in lung sounds if we never auscultated their lungs upon admission? So it's important that we do a nice head-to-toe assessment on these patients, get their vital signs, assess them for signs of fatigue that we know from could occur from an increased cardiac workload there. Signs of congestion heart failure that we just reviewed, and weight. Is the patient all of a sudden, having that pitting edema exhibited? Does it look like they've put on, several pounds of weight in a short period of time? And we always want to touch base with our patients as well. Our patients are typically awake and alert and oriented and able to give us information, especially if they have been living with this cardiac disease for a long time of their life. They really know their bodies. So it'd be a great source of information to review with them. We want to assess our nursing-based interventions. So teach our patients about what we're looking for. Talk to them about that weight gain and that edema. All of a sudden, do your rings feel tight or your watch tight? Is that different? That's what I'm looking for as your nurse. I want to assess for those changes in weight gain there. Exertion, emotional stress. How are you feeling? What's going on there? What is working? What is not working? Want to touch base to help the family accept kind of restrictions on activities, especially if, parents and family have different social and cultural expectations for where the mom should be, quote unquote, in her postpartum period, and what her goals are for activity there. We also want to continue to provide appropriate postpartum care, understanding that other than having this history of cardiac disease, this patient also is a postpartum patient who does require some important postpartum care there. Anemias. We can see many patients in the hospital setting in labor and delivery with a variety of anemia as their background. It's important that we understand that each anemia has perhaps a different way that it can be managed therapeutically and how that impacts their care. Iron deficiency anemia, folic acid anemia, sickle cell anemia, and thalassemia, all kind of different types of anemia, different pathologies there as to how they are worked through in the body. Immune complex diseases, so systemic lupus, patients who have Hashimoto's thyroiditis, rheumatoid arthritis. So these, again, immune complex issues, these are issues that perhaps have some sort of hormone involvement. That's important to understand their role in the development of a fetus and how that impacts pregnancy. Is pregnancy a big stress on these illnesses? How does it affect fetal development? And is medication used to manage the signs and symptoms of this, or the therapeutic management of medication? So it's important that we understand that even though our patients, I would say, typically are healthy and well and have healthy and well babies, there is, an inherent population of patients who have a background of complex medical issues. So it's important that we understand how to care for these patients appropriately and provide them safe prenatal care as well. Infections during pregnancy, which can affect the fetus as well and do require a good amount of medication management, include things like varicella zoster, which is also known as the chicken pox, herpes simplex, which can prevent a vaginal delivery if there's active lesions in the vagina and vulva. If those active lesions are there and present, they can cause very severe effects on the newborn, such as blindness even. So it's important that we assess our patients for any history of these and then kind of follow that history of these underlying illnesses throughout the pregnancy, monitoring how it impacts their labor and birth as well as the health and safety of their pregnancy. Infections during pregnancy which are non-viral include toxoplasmosis, group beta strep, as well as tuberculosis. Group beta strep is a very, very common non-viral infection during pregnancy. It's essentially a culture that kind of lives on our body normally throughout. The only time it's really pertinent is during labor and delivery, because that group beta strep can be passed to the fetus, especially once those membranes are ruptured, that fetus is exposed to the group beta strep culture. So it's important that these moms receive antibiotics during their labor and birth, even if their water hasn't broken yet, in order to protect that baby from being exposed to that type of culture. Last question, glucose metabolism is profoundly affected during pregnancy because, all right, and then you have some options there for your question.